Hi, everyone, and welcome to this event hosted by the ISPOR KI Student Chapter from the ISPOR Student Network. My name is Camila, and together with Carla, we are representing the chapter's board. And today we have two great speakers that are going to discuss about the PATHFx project, which is a precision prognostic decision support tool supported by machine learning. So our first speaker is Rikard Wedin. He is the co-developer of PATHFx together with Professor Jonathan Forsberg. And Rikard is an associate professor at KI, and he's also a senior consultant at Karolinska University Hospital. Our second speaker is Elena Minenko, and Elena has worked as a medical doctor within neurology, project manager, and also a product manager. At PATHFx, she provided some consultancy services in the field of health economics. So we will have two talks lasting for about 15 minutes, and we will leave the questions for the end of the talk, but please feel free to ask questions in the chat during the talk if you have any. So we will start with Rikard. Welcome, and thank you for joining us.
Hi, everyone. Yes, thank you for inviting me. I'll be talking about PATHFx. So, when the cancer spreads to the bone, the patients are incurable. The tumors cause pain, fractures, and also paresis when the spine is invaded and compress the spinal cord. And this afflicts 75% of patients with advanced breast cancer and half of the patients with advanced prostate cancer. A fracture caused by cancer seldom heals, and the bone quality is often very bad. So there's a high risk of complications and new operations. And the new operation is more or less a catastrophe for a patient that has a median 7 months to live. To reoperate a fracture cancer patients is one of the most costly surgeries we do at hospitals today. And the costs are increasing rapidly. If you work with these kind of patients, sooner or later you will get this question, but doctors don't really like to answer this question because of the great risk of being very wrong. There's no objective way to estimate survival. So the patients are often left in uncertainty. Physician estimates of survival are problematic for a variety of reasons, and they are most often too optimistic. These are Kaplan-Meier curves, and the curves to the right are more optimistic, represents a longer survival, and the curves to the left are more pessimistic, shorter survival. 258 oncologists in this study were asked to estimate the survival of 326 patients with metastatic bone disease, and this is the outcome. What the oncologists actually thought, what they estimated, is the curve in the middle. What they communicated to the patient was a different ballgame. They didn't want to bring bad news, so they kind of gave a better prognosis. And what happened? Well, this is the curve to the left. The patient had far worse survival. So we are optimistic, but that doesn't benefit patients, at least not when it comes to treatment. So expected survival is very important when planning the surgical treatment. Patients with long expected survival, like 1 year, they should have durable, expensive constructs like these prostheses, but the prosthesis demands a long rehabilitation. Patients with shorter survival don't have time for long rehabilitation. They benefit from other constructs like this intermedullary nail. And finally, patients with very short survival, they usually don't benefit at all from surgery. So to choose the wrong treatment is costly for the patient and the healthcare budget. So why is this important? The doctor's job is to maximize the functional mobility and the quality of life for the maximum amount of time. A less invasive treatment, like here to the left, doesn't require much rehab, and patients are up and around right away. Unfortunately, it is also less durable, fatiguing over time, like a paperclip seen here. The prosthesis, on the other hand, is much more durable and can last many years, but it comes at a cost in terms of operative morbidity and the length of rehabilitation required. This is Jonathan Forsberg on the right, my American colleague. He's at Johns Hopkins Walter Reed. He wrote his thesis at Karolinska. I was his mentor, and this was the start of our clinical decision support. So PATHFx is our clinical decision support that prognosticates survival of patients with symptomatic skeletal metastasis. It's based on machine learning and Bayesian statistics. And Bayesian statistics is the reason for that is that it can be okay if you don't have all the data put into it, unlike logistic regression, because that is how it is in a clinical setting. You don't always have all the data. Anyway, PATHFx is available to mostly validated users. It's worldwide, it's free of charge. And yeah, almost all users are healthcare professionals. So this is how it works. You get 11 questions. It's about age, sex, what type of cancer you have, the primary tumor, an easy functional score, whether the fracture is complete or it's impending, threatening, then hemoglobin concentration, the absolute lymphocyte count. The lymphocytes are the white or type of white blood cells. The number of skeletal metastasis, whether it's solitary or there is multiple metastasis. Spreading, whether the tumor has spread to the lungs, liver, or brain or not, and whether the lymph node metastases are engaged. Then if you're an expert in the field, you can add to the prognosis, the sharpness of the prognosis, if you do your own estimate survival in addition. If you're not an expert, you should leave that blank. So this is how it looks. This is the response you get. This is the probability of survival here in percent, and this is the time frame, 1, 3, 6, 12, 18, and 24 months. So in this particular patient, the probability for survival is around 30% for 1 year, around 60% chance to live for 6 months. This is a graphical plot of one of the 6 different time or survival models. Is the 3-month survival model. All the variables in these boxes do significantly affect the prognosis, but the variables in the red boxes are most important ones for survival more than 3 months. The blue box, the survival, the outcome. Interestingly enough, these 6 different algorithms or models all look a bit different from each other when it comes to these variables being most important. Anyway, on cross-validation, we saw that it was sufficiently adequate. The area under the curve was 0.6. We started off with 2 of these algorithms, 3 and 12 months, but now we have 6 models to be able to easier differentiate between our treatments. So how do we know it works? If you want to use a clinical decision support, you need to make sure that it is validated for the group of patients you're using it to. To date, we have externally validated PATHFx in 4 different regions in the United States, in the Nordic countries, in Italy, and in Japan. And recently also an independent group from Australia validated PATHFx. So this is the scientific proof. It exists in 2 versions. It's available free on the internet at this address, but much better for everyone is when it's integrated in the patient medical record, like here at the NIH in Washington. No login necessary, and the computer might answer half of these questions by itself. So we have around 1,000, 1,100 registered physicians at the moment. They're mainly from the United States and Europe, but there are users from all over the world. Most of the users use their desktop, 1/3 use their mobile phone. Some months ago, we presented a patient case on AuthorBullets. AuthorBullets is the largest educational platform for orthopedic surgeons. And within an hour, we had 31,000 doctors looking at this case, where we talked a little bit about PATHFx, and that was really good. So PATHFx will always need to be updated since cancer treatment and the prognosis are changing rapidly. In our new version 3.0, algorithms have been retrained with patient datasets from our International Bone Metastasis Registry. It's a high-security web-based registry located here in Stockholm, hosted by the Regional Cancer Center. And these university centers are our collaborators providing data to our registry. This is just a front page of the registry showing a little bit about the variables we are asking for. So why do international cancer centers send us data? Well, it's a modern, high security registry, and it's free of charge. And every center owns their own data. The benefit is that we will be using exactly the same variables, all of us, so it's very easy to do international comparisons. It's very easy to do studies together. And the gain for the registry is, besides providing these data for research in this field, we could continuously update our PATHFx variables. Finally, what are our future goals? Well, we'd like to continue to improve the precision, of course, based on an increasing amount of data from our registry. We would like to construct disease-specific models, like one PATHFx for breast cancer, one for prostate cancer. We are a little bit on our way with that. Of course, find new prognostic variables with the help of our registry data. Specifically, we're now looking at immunotherapy because that seems to change the prognosis quite a bit. And of course, our vision is to make PATHFx the standard tool for all physicians treating patients with metastatic bone disease. Thank you.
Thank you very much, Rikard. That was a very interesting presentation. We will now hear from Elena. If you can just stop sharing your screen and Elena can share hers.
So hello everyone, my name is Elena. I would like to thank you for inviting me and presenting my work to you. So today I want to show you my work on health economics analysis of PATHFx. I would like to show you not only final results, but actual process, how we worked on it, and what was important in this analysis. First, I would like to say that there were several main parts. First of all, we needed to understand goal of the analysis, and goal was to identify cost savings in case of use of PATHFx as predictive tool in treatment of patients with bone metastatic disease. Second main part was actually to understand present situation with standard treatment here in Sweden. Who are those patients who are treated, how they are treated, and how much it costs. Next stage was to identify effect of PATHFx toward treatment and how it affects eventual costs. So first part was understanding the clinical situation, and it was a crucial part because it was base for whole analysis. In order to understand this clinical situation, it was great help from Rikard and his expert information on patients, their situation and types of treatment they get. So actually we identified ICD-10 codes of main disease and complications. We also identified surgical codes for procedures used to treat these patients. And based on these codes, we could identify drug-related groups. Drug-related groups allows to see costs of treatment and costs of care of different patients, including inpatient care, outpatient care, and rehabilitation. What is important that this process was iterative, and each new iteration gave us more and more information. Eventually, we created two schemas that show standard process of treatment for patients with bone metastatic disease. Here you can see first group of patients who had metastasis in spine. And for them, it was available to have two main treatments, treatment A, treatment B. After treatment, some patients may have complications that would also require more treatments, surgical and non-surgical. And after that treatment, some patients could have complications as well, and we assess the possibility of treatment for them, surgical and non-surgical as well. So for all groups of treatments here, we calculated costs of inpatient, outpatient care and rehabilitation. Then we have second group of patients, those who have bone metastasis in extremities. And you can see here in this picture that there were 4 groups of treatment. And for each of them, we also identified complications, types of complications, and possibilities of treatment. What was interesting that depending on hospital, level of complications could be different. And as a result, level rate of reoperation surgical treatment also was different. And we used this information in order to present final results, which you will see a little bit later. So after identifying these 2 groups, main groups of patients and costs for different situations of complications, we could calculate main figure, this cost of standard treatment here in Sweden. After that, we used information about the effect of PATHFx on treatment, how it affects particular rate of reoperations or non-surgical treatment. And based on this, we could identify costs and eventually cost savings. The result of our analysis can be seen here. So it's presented depending on effect of PATHFx here on the left side. It could be -10%, -15% of reoperation rate. And depending on hospital situation, if hospital has reoperation rate 30% or 10%. And eventually, PATHFx provides cost savings from 4.6 to almost 14%, depending on particular situation in hospital. Thank you.
Thank you very much, Elena. We will open for questions now. If you have any questions, you can put it in the chat. We have already 2 questions. One, I think it will be with Rikard. The question is, how do people that are not familiar with machine learning react with this kind of tool? For example, doctors, if they are confident on using it?
Both yes and no. They should all be aware of that this is a probability, what they're seeing, the prognosis they are getting. Everybody knows that the patient could pass away next week in an infection. But just by entering answers to these 10, 11 questions will make the doctors think about these variables, these significant variables that changes the prognosis. So that will give them the possibility to do a more educated, a more intelligent guess about a prognosis for the patient. So there is skepticism, but after doing this, they are on a higher level and better able to make a better treatment plan.
Okay, thank you. And maybe for Elena, were your results used in any practical case, any application?
My part of work was initial work of health economics analysis, and these data were used afterwards for further analysis, which I was not part of. So I don't have any information at the moment about progress.
We are presenting this data to hospitals and healthcare officials about the possible savings that could be done, not just improving lives of patients, but also improving healthcare budgets. So this study that Elena performed is a very important information to healthcare providers.
Okay, thank you. We have another question. What databases have you used for the model training, and how many cases have you trained your model on?
Okay, I was afraid of this question because the machine learning technology is actually from the US Navy. Jonathan Forsberg is using their lab and their technicians for the ML. So I have to pass on that question. The initial database was only 180 cancer patients from Memorial Sloan Kettering in New York. And further on, we've been using 850 patients from my Karolinska Registry, and we're working on bigger databases now.
So at first, you didn't have the international registry, and you used data from the US.
Yeah, actually, Jonathan did the initial testings with Memorial Sloan Kettering patients, and he contacted me because I had a far larger database collecting data from our Nordic countries. So I had like 1,400 patients. So that was the start of our project. He was sitting mainly on the machine learning technology, and I was sitting on the data.
And another question is, how many people are working with this project? And my question is, can students get involved in some way?
We are very few. Jonathan do the research at Johns Hopkins Walter Reed. He has some assistants. I run the registry by myself. The way to get involved, I think, is the way we got in contact with Elena. We're helped by an innovation, by the Karolinska Innovation. What's it called? Innovation AB. And there is possibilities for students to help out and get some salary for it. So contacting innovation hubs, or there is so many startups within the Karolinska environment right now. So there should be ample possibilities to get involved.
Yeah. Thank you. Another question, what about interpretability of the model? Have you worked in reverse engineering being done in order to understand what variables are the most informative?
Yes. First, we started off checking every possible variable that could affect the survival of these patients, and we picked the significant ones. But then again, I'm not so, I don't know very much about the machine learning itself. So I'm fortunate to have to pass on that question as well.
Okay, another question. What is the output of the model? Survival time, 5-year survival rate?
Yeah, it's the probability of survival at these 6 time points. The ones that 1 month, 3 months, 6, 12, 18, and 24 months. The 1 month is the least accurate one, and those short survival times, patients that survive that short, it's also very, very difficult in the clinics in real life to estimate their survival. The 3 and 9 months are the most, has the best results in the area under the curve. We haven't any models going further than 2 years because it's extremely few patients, unfortunately, that survives longer than that.
Yeah, I was impressed. I didn't know it was like such a short survival.
No. The median survival in the Karolinska material is somewhere around 7-8 months right now. When I started this 20 years ago with my previous research, the median survival was less than 6 months. So now it improves. Survival times improves from most of the cancer types.
Yeah, that's good. Another question, does the training data sets and test data sets both come from the international register? How about the validity on outside data?
No, it wasn't, what should I say? It has been externally validated with data sets from US, separate data sets from the US, from the Nordic countries, from Italy and Japan, and also Australia. So it has been kind of thoroughly validated in different patient populations. And also, as I said, by an external group from Australia. And it's been increasingly recognized, and we're expecting more external validations. And just last week, I got a mail from Taiwan. They had a pretty huge data set that they want to test on PATHFx. So we can expect more results soon.
Great. For the health economics analysis, what were the data sources used for the study?
For health economics analysis, open source data were used. In order to calculate costs, we used NordDRG groups. Social Styrelsen provides information on these groups and costs here in Sweden for each year, and these data are available for everyone.
Is it data from the whole Sweden or Stockholm?
Yes, data for whole Sweden. Yeah.
Another question, if we talk about numbers to compare, how much does it cost at the ordinary way of treating patients and with using the clinical decision support?
I can tell you that there is a difference in those percentages that I showed, about 14%. So,
do you have the absolute numbers?
Not at the moment, no.
I could just add that the costs of these operations, they run between, Elena, correct me if I'm wrong, somewhere between 50,000 Swedish crowns. What that is, that 6,000 American dollars to, if you multiply that with 4 times maybe, especially for reoperations and spinal cord compressions, they can be very expensive. Reoperations are, of course, most expensive. And if a patient that we reoperate end up in the intensive care units, you could multiply that sum with 10 at least.
Yeah.
Yes, and we also calculated rehabilitation and outpatient care.
That's correct.
Mm-hmm.
Forgot about that. That number, as I said, like $5,000-6,000 is just for the
Surgery.
2 days in hospital, not counting the rehabilitation time, which is much longer than that.
And what about this reoperation? The chances for reoperation? Have you considered this in like in the outcomes? For
Again,
comparison, have you considered the outcome as chance for reoperation as in the analysis, in the health economics analysis?
Yes, Elena, should you answer that question or?
Yes, we consider different reoperations rate from 10% to 30%. That's why we show result for each chance of reoperation.
And those, why is it different between different hospitals? Well, this is these are kind of rare patients, and the fewer patients you treat, the higher complication rate you have. The more patients you treat, the better you get at it. So we have previously seen that the reoperation rate at hospitals that treats very few patients is very much higher than in hospitals treating a lot of these patients.
Yeah. Another question, what are the incentives for doctors to use the tool? Is it voluntary? Yes.
Of course, voluntary.
Yeah.
Well, the reason is that the reoperation and complication rate is so high, and it's not. It doesn't give a good feeling to doctors either to have bad results, to have patients coming back and they have failed reconstructions. So of course, everyone wants to treat their patient as good as possible, and by estimating the prognosis, you could provide patients with short survival. You could provide them with a method of reconstruction which enables them to come home, to be with loved ones instead of spending long time in rehabilitation places. So doctors want to do a better job and to make a more informed decision.
Do you consider any kind of plans to increase the adoption of the tool?
It's difficult. We've written, as you saw, quite a few papers, publications. We have like 6 of our own, 7, I believe. But usually it's only experts that read papers, that read publications. The doctors seldom seeing this patient. The doctors working in northern Sweden, they usually don't read papers, so it's difficult to reach them. So it takes a long time until our information reads or reaches everyone. So we have to be patient. It's difficult to be patient.
Thank you.
We can't do commercials on TV really, or we can't buy ads in papers. No, we have to rely on that the scientific results slowly spreading down to the users, to the doctors.
There's another question. Do you manage to collect patient data systematically? Do you have ongoing international studies?
Yes, as I said, with this international registry, we collect all the patients operated at Karolinska Hospital, at the Copenhagen University Hospital in Finland, and the Johns Hopkins Walter Reed, and we have from Cape Town, and we have from Singapore and University of Tokyo. So, more centers are interested in joining. So we are expecting this registry to speed up, to collect a lot more data. We have around 1,000 patients, 900 patients, somewhere like that right now, but we're expecting a surge soon.
Okay, thank you. Maybe if we have some more questions. Well, in the meanwhile, thanks everyone for watching and for asking the good questions. We will have 2 more events in this semester. One, it's the use of benchmarking and register data to assess the performance of orthopedic care on May 3rd. And the second event is Valuing for Innovation, the consequences of value-based assessments for medical devices. So if you enjoyed this event, please check our Facebook and yeah. Oh, and we also have a recruitment open. If you'd like to join the team, we are looking for several positions and you can apply. Just send us an email with your CV and motivational letter. And I believe we don't have any other questions. So I would like to thank you again, Rikard and Elena, for being here and presenting PATHFx.
Thank you.
Thank you.
Thank you very much. Have a lovely afternoon.
Thank you. Bye.
Goodbye.